Thank you, chairpersons, for this kind introduction. Right at the outset, let me wish all a very good morning. I have the honor of being the opening batsman of the day today. So I hope I set the note and the tempo. So thank you, organizers of Yuva Isar, for this wonderful opportunity. It's the first physical conference we are attending. So everyone's really excited about this. The topic of the day is ovarian stimulation protocol in poor responders. And I hope that I'm sharing some Ande ka funda. So, with regards to poor responders, I think we all are aware of the Bologna criteria. It's the easiest criteria to remember. It's basically poor responders form a group of people who have either advanced stage, more than 40, abnormal ovarian reserve test, or previous poor ovarian response to stimulation. But much later in 2015, we had the Poseidon criteria, which was very more kinder as compared to the poor responder terminology, because it said that we should call people as low prognosis patients and not, because that is the ideal terminology. It is more kinder and more gentler for the patient to hear as well. And it basically has distinct categories of patients depending upon the age of the patient, ovarian biomarkers, and the ovarian response of the patient provided in the previous cycle. And there are 4 criteria. There is category 1, group 2, group 3, and group 4, which we are understanding that groups forms a very important base in today's discussion. Have you all ever wondered, is there any best protocol for poor responders? We all have this subset of patients, and poor responders are some of the most difficult patients amongst the subset of IVF patients. There is no, we all agree that the most successful and ultimate treatment for poor responders, poor ovarian reserve, POF patients is basically egg donation. That forms the ultimate thing. But not every woman is agreeing to egg donation, and not every woman accepts egg donation. And then we have to look for alternative solutions, which despite the low odds for success, sometimes need to be employed in interest of the patient. And there are, other than various anecdotal cases, there is no unequivocal treatment which is provided, which is successful for these patients in any kind of prospective randomized control trials. But yet we have to do this trial and error, and we have to give our patients what they want. So today I'm going to be discussing about how we can individualize our ovarian stimulation protocol to better provide a service to our patients. There are 2 concepts that we need to understand. One is the follicle to oocyte index and the number of follicle output rate. It is not only poor response that we are thinking about, it's also the hypo-responsiveness. So if you see this chart, there is something called as normal FOI and low FOI, and I think this is a very nice diagram which depicts what hypo-responsiveness means. That means if you are seeing an antral follicle count which is as high as this, but the number of oocytes you get in the end is very less, then these are the low FOI subset, and this hypo response is what we are more worried about. What are the treatment options available? I'm not going to talk about the pre-IVF treatment options. Within the IVF cycle, during the stimulation, we have only the modification of protocols that we can do. There are dual stimulation protocols, which Dr. Manisha is going to talk after me, so I'm skipping that. There are various triggers which are available, which Dr. Sheetal is going to elaborate more upon. Increasing the dose of gonadotropin is what we all will instinctively do when we see a patient of poor response. Addition of LH, day 2 transfers, lab protocol changes. These are whatever we can do during the IVF stimulation protocol. The conventional long agonist protocol is the gold standard in IVF. That is something that we compare everything against. And what can we do to modify this long agonist protocol if we want to tailor it to poor responders? Well, we can decrease the length of suppression by decreasing the duration of GnRH agonist, use like a short protocol or an ultra short protocol, a mini microdose flare protocol. We can lower or stop pituitary suppression as soon as the luteal phase is over. We can use GnRH antagonist protocols. So GnRH antagonist, after it came, I think most of us have almost switched over to the ANTAC protocol. The advantages of the ANTAC protocol is that we are able to assess the ovarian reserve on day 2, day 3. We are able to use drugs like corifolitrofin alpha. We see a rapid increase in serum LH, thereby getting probably a more higher exposure of the antral follicles to high levels of FSH. But is it the perfect protocol? We all face problems with the ANTAC protocol after completely switching over. Way back in 2011, we were only doing the long agonist protocol, at least I was. And suddenly in 2013, we completely switched to the ANTAC protocol. But definitely it is not the perfect protocol. We all know that despite these advantages, there are so many things that don't work for all patients. And is it possible then to predict that which patient set is not going to respond to the ANTAC protocol? So this is a review of literature comparing the agonist and the ANTAC protocol. And what I'm seeing is that the antagonist was better up till 2006. These studies up to 2006 irrevocably said that ANTAC protocol is the better protocol. Suddenly in 2009, papers started coming up which said that maybe the long agonist protocol works better for poor responders. We wonder what happened suddenly, what changed, why this sudden shift of views. And what came on the horizon was PGS. And PGS brought with it the concept of a transferring of a single euploid embryo. And here, what the review of literature says, that with the long GnRH agonist protocol with a proper suppression, we probably get increased number of mature oocytes by 1 or 2 oocytes. So it's not like really 10 oocytes which we get more or anything. But when regards to poor responders, that one oocyte can also increase the live birth rate by 5%. And that is what we see with the long agonist protocol. The cancellation rate is significantly lower. This is due to better follicular synchronization, which is in expected POR patients of utmost importance. And so although in studies you will not see a statistical difference in the live birth rate or the difference, it is just that one mature oocyte that we get more with the long agonist protocol. And that is why there is so much discrepancy and so much doubt. Just yesterday I was speaking with one colleague and we were discussing what really is the evidence saying, is the agonist protocol better or the ANTAC protocol better? But this is the difference when you really look at the studies in depth. It is just that one follicle. This is one huge meta-analysis with 1233 POR patients which said that there was a lower cancellation rate, higher implantation rate and a higher live birth rate which was found in young POR. If you see the difference, it is not really statistically significant, but it is basically also telling us that probably for the Poseidon 3 group, which is the young patients with low AFC and low AMH, those are the group patients for which probably GnRH agonist protocol may be used. So in conclusion, if we are able to individualize that way, if we are able to use the Poseidon criteria to our advantage and then use it only for the group 3 patients, then maybe you can choose the long agonist protocol over the ANTAC protocol. What are the other types of ovarian stimulation protocols that we have? We have the mild stimulation protocols, the moderate stimulation protocols. This is this is a table summarizing the studies that compare the natural protocol as against the long agonist protocol. And yes, we see that maybe per ET per cycle, the implantation rate is definitely better with these natural protocols. If we see the cumulative pregnancy rate, yes, with 3.549 cycles per patient, we do definitely see that there is a steady increase in the cumulative pregnancy rate with each ongoing cycle, and that is probably the advantage of a natural cycle protocol. The only problem thereby is that there is a lot of fine-tuning which is required for a natural cycle or a modified natural cycle, and it requires a certain degree of expertise and certain time and dedication. It requires a team. If you have that, then yes, the natural protocol, the mild stimulation protocols, the minimal stimulation protocols definitely offer a better chance along with embryo pooling. We have great vitrification rates today, and along with embryo pooling definitely serve as a good option for these patients. With regards to egg quality, this is one study that says that with the mild stimulation protocol, definitely, if not worse, the egg quality is similar to the conventional protocol. We get the same number of euploid embryos eventually, and probably the cost is much lesser as compared to the conventional protocol. So these are the advantages and the disadvantages. One another advantage which really does not matter in poor responders is that the risk of OHSS is lower. Embryo quality, if not the same, it could also be better with the minimal stimulation protocol. Also, it's more friendlier on the endometrium. To conclude, it is a low-cost protocol, less risk, higher satisfaction. Only drawback is that a specialized clinic is needed, higher flexibility of the patient and the staff is required if we are going to opt for this protocol. Another protocol that is spoken very often, I have been very fond of this protocol, is the ultra-short Gnrh agonist protocol that employs the flare of the Gnrh agonist in the first 3 days by giving 0.25 micrograms of leuprolide or buserelin. And this ultra-short protocol definitely is a good advantage. You can also use OC pills in the pre-treatment cycle, and it offers certain advantages in synchronizing the cycle. It suppresses the pre-stimulation FSH without blunting the FSH flare, and it does not affect the follicular phase. So along with the pre-IVF OC pills, I think ultra-short protocol is a good protocol, and that is what the literature also agrees, that a lot of these randomized control trials say that as compared to the conventional protocol or the ANTAC protocol, the ultra-short protocol definitely is having better number of mature oocytes which are retrieved, better fertilization rates, and better top quality embryos transfers. What the literature also says is probably this protocol is something that we should try for the ones with repeated IVF failure. Again, Poseidon 3 and 4, people who have had a poor ovarian response in the past, this protocol is probably something that would work. This talk cannot end without talking about growth hormone, because that is another modification to ovarian stimulation protocols that we can do. Administration of growth hormones potentiates the effects of exogenous gonadotrophins. It does that by modulating the action of FSH on the granulosa cells by upregulating the local synthesis of IGF-1. And this is supposed to stimulate follicular development, increase estrogen production, and oocyte maturation. So a lot of studies have kind of concurred with this logic. The only problem with growth hormone is that it's still an off-label use. We don't have enough randomized control trials which are kind of fine-tuning the stimulation protocols. And there is always that fear that if something goes wrong, we are using an off-label drug and it may not work. But even in growth hormone, what the RCTs say, that you can't just about use it for all unselected patients. It is definitely only for those patients who have had a previous suboptimal response. And if you use it generally, then there is no difference in the IVF outcome. But in this subset of poor responders, most of the RCTs say that without having any adverse events, there would be an increased success rate. That is what most of the studies are saying, that poor responders, especially those with a positive clonidine test, the ones with a negative clonidine test, where there is not enough endogenous growth hormone, those can be stimulated by augmentation of the central cholinergic pathway. And in these people, if we can't administer growth hormone, then administration of an acetylcholinesterase inhibitor like pyridostigmine might also increase the chances of a better response. Here, obviously, better studies and better research is definitely needed. Because growth hormone is still not considered conventional or not considered the label kind of stimulation protocol. So we have to do some work on it. So looking back at the trends of the last 5 years, what are the popular protocols? Yes, antagonist protocol is what people have been using more until 2009. But after 2009, I think most of us are exploring other protocols. And the microdose protocol and the letrozole plus FSH plus antagonist, all these protocols are also getting more and more popular. And it's worth kind of individualizing your ovarian stimulation protocol with regards to the kind of subset of patients. What is the choice of gonadotrophin? Will it really change the outcome? Neither does the dose, increasing the dose beyond a point affect the success rate, neither does the choice affect that much. Increasing FSH doses, especially beyond 450, is not associated with IVF outcome. This is a really nice study that said that whether you start at 300, 450 or 600, in terms of the retrieved oocytes or in the terms of the number of embryos or pregnancy rate, it really did not make too much of a difference. The same it with regards to gonadotropin usage. In this subset of patients, yes, recombinant FSH, recombinant LH probably will give you that one additional oocyte, mature oocyte, but it is not translating into like a significant difference. That's why if you go back to see the Gnrh guidelines, it really states clearly that whether you use recombinant HMG or recombinant FSH or plain HMG, highly purified HMG, it really does not make too much of a difference with regards to poor responders. So it is really the time of individualized controlled ovarian stimulation, especially in the group 4 Poseidon. We should have kind of change the criteria. Here they have mentioned what are the kind of protocols that you could probably use, and both for group 3 as well as group 4, the long agonist protocol as well as the antagonist protocol has been recommended, but only in group 4 they have said that you can also add LH at the time of the stimulation. So probably this subset of patients is for whom you can spend extra on pergorellis and use that recombinant LH, because it really probably would make some difference. Also, this is the set of patients where you should at least initiate the talk about egg donation. That is what this meta-analysis says. This is a nice meta-analysis by Andro Estevas and published in 2018. It really clears a lot of funda with regards to poor responders. Whenever we stimulate a patient with poor responders, I think these statistics are something that we should mention to the patient. That means we have to tell them what is the number of oocytes and the live birth rate. So if you get something like 3 oocytes, then the live birth rate is as low as 15%. So we have to kind of show them these charts. We also have to mention to them that number of oocytes and age both have a significant outcome on the live birth rates. So if you have a patient who is above 40 with only 4 oocytes, then the success rate is 7.5%. It is nice to know this, because then you can decide whether it's worth that whole exercise. And supposing the age is 18 to 34, in this subset of patient, if there are 4 oocytes, then you can see that the live birth rate is 25%. So if you tell the patient these statistics, it makes makes life easier for the patient to take the decision. Going back to the Gnrh guidelines have kind of summarized all that I said today. They have said that recombinant FSH and HMG for ovarian stimulation is equally recommended. The use of recombinant RFSH and purified FSH for ovarian stimulation works equally well, and the use of long-acting daily RFSH is also equally recommended. Gnrh antagonists and agonists are also equally effective. Clomiphene citrate alone or in combination with gonadotropin, that means the mild or the moderate stimulation protocols, are also recommended for predicted poor responders. Only thing that they have mentioned is letrozole is probably not recommended as a substitute for gonadotropins or clomiphene citrate when we are using the mild or minimal stimulation protocols in poor responders. And a gonadotropin dose higher than 300 IU is what they have said is not recommended for predicted poor responders. Lab work is equally crucial. It is not part of my talk today, but yes, definitely standardization of lab environment and culture conditions. You want your embryologist to even search for that one oocyte, and improving the lab conditions, having a good vitrification pooling program, probably doing a day 2 embryo transfer sometimes versus a day 3 when you have poor response works better in poor responders. There is no additional benefit with assisted hatching or follicular flushing, and that is what most of the studies say. To conclude, poor response is seen in 9 to 24% of patients. Various pre-cycle interventions and protocols have been proposed and tried. We have our own cocktail regimens that we all give our patients, and it is there's no unequivocal data about that, what is the best cocktail that is available in the market. There is insufficient evidence to support the routine use of any particular intervention for pituitary downregulation. So really, we still have a lot of work to do with regards to poor responders. There is no solid data which says that there is any magic bullet for any of these patients. We just need to probably use some clues from the scientific evidence, and maybe for those, to summarize, for the young Poseidon 3 group, use the long agonist protocol once in a while to get that one extra oocyte. We need to be conservative about how much the patient is spending, so don't go beyond 450 IU. And in patients with borderline growth hormone deficiency, maybe we can explore the option of using growth hormone. With that, I could conclude my talk, and I welcome any questions that the audience or the chairpersons may have. Thank you so much.
Thank you, Dr. Shrutika, for the wonderful presentation. It was very well covered, covering all the aspects of the important adjuvants that cross our mind when we deal with the poor responders, and especially the point where you clearly stated that Ignis protocol is definitely better in a young poor responder, because this has been a confusion for a very long time and has still not been cleared. I've never heard anybody speaking so clearly, promoting long protocol for a young poor responders so clearly. Thank you so much. Thank you.
Dr. Shrutika, if I can just ask you something. From your personal experience, what do you feel? I mean, what do you use for, especially for young poor responders, and maybe a little bit about the elder
I'm
poor
just
responders?
about beginning to start using the long Ignis protocol again. But the maximum experience that I have, and usually what I do is the ultra short protocol or then dual stimulation. I purposely didn't talk about dual stimulation because Dr. Manisha is going to talk about it. But I have got a very good success rate with dual stimulation protocols and freezing embryo pooling. So the only advantage that I'm seeing with understanding the Poseidon criteria is even if the patient has not undergone IVF in the past, then we are able to educate the patient that probably, at least quote them, explain the financials to them, that if you are going to be a poor responder, then maybe we will change the trigger, we will kind of pool the embryos, and we might have to do a second stimulation, sometimes a luteal phase stimulation or another cycle. So I think that counseling is really making a difference. Thank you. Yeah.
For improving the ovarian reserve, or it's for the response?
So DHEA I think we have all been using for the longest time, and definitely there is a jump in the AMH that gives the patient some confidence, and maybe the quality of the oocytes is better. The scientific logic about DHEA usage, that the androgen substrate that the granulosa cells will get does make perfect sense and logic to me, to my mind. But with regards to androtas or any of those androgen gels, I really don't see too much of a difference after using it for 1 month.
So is it in the reserve or the response? My question is whether it
I
helps
feel
to
that
improve the reserve or the
the quality
response.
of the oocytes is better after 3 months of DHEA at least. But with regards to the androgen gel, I neither see a improvement in the response or the numbers. So I'm not sure.
It's
Yeah, I'm
basically
not
the
sure
reserve.
whether the
Yeah, oocytes. Okay. Thank you. Thank you,
Can I
Shrutika.
just add on to this? I think the ovarian reserve is fixed when a woman is born. There is no medicine which can change the ovarian reserve.
what they mean is the pool of antral follicles.
The pool of antral follicles for recruitment might be better, but I mean the authors who made the Bologna criteria, they just recently published a paper on using testosterone gel in Bologna poor patients. I think it just got published 1 month back, and even they stated there is no role of testosterone gels or androgens
No, I
in these
think the
patients.
FOI does not change. Eventually, even if you see more antral follicles, no, the oocyte, the output is not changing. No, but we are not seeing a difference in the FOI.
That is what they are saying, that even after 1 year and repeated stimulations, there was no end result in terms of more number of mature oocytes and more number of embryos. See, even though there are a higher number of antral follicles to begin with, the end result is still the
If
same.
the FOI is the same, it really doesn't make a difference whether you see good number of antral follicles. That is what. I think we are still exploring it. Thank you so much.